Well, welcome everyone to Grand Rounds, and I will begin as I always do by thanking all of you for coming and spending your Friday morning here. I really think, knowing our speaker, you're going to find this Grand Rounds incredibly educational, innovative, and really helpful for really kind of any work you do if you work with smokers. So our Grand Rounds presenter today is Dr. Jessica Cook. She's a PhD with us in the Department of Medicine. She works within the Center she works with C-Tree people. Can you raise your hands? Okay, great. So she works in the Center for Tobacco Dependence and Cessation, and I'm saying the Center for Tobacco Research and Intervention. I ran over here, sorry about that. But C-Tree, as many of you know, is one of the cornerstones for the research portfolio in the Department of Medicine. It's known nationally and known internationally. And Dr. Cook is going to further our knowledge in that area. She did her master's in clinical psychology at University of Illinois Chicago, which was followed by her PhD in clinical psychology at University of Illinois in Chicago as well. She did an internship at the VA in Puget Sound, and she followed that with a postdoctorate research fellow at the VA Northwest Network Mental Illness Research, Education, and Clinical Center. We were very lucky to have her come and join us, and we were her first job after that training. She came on as a clinical psychologist working with PTSD at the VA in 2008, and she was promoted to associate professor in 2017. She has some leadership roles, including being the director for tobacco dependence curriculum implementation at the University of Wisconsin Medical School here. She has several awards, and one I would like to highlight is she did receive an NCI Travel Award for Early Stage Investigator in 2012. She has over 57 refereed articles, 35 national presentations for which she was invited. She has 2 VA merits. She's been incredibly successful, and we are very lucky to have her on our faculty. Come on up.
Good morning. So today I'm going to talk with you about how to treat smokers who are not ready to quit. I'd like to thank NCI and the Wisconsin Partnership Program for funding this research. It's a center grant awarded to UW, Center for Tobacco Research and Intervention. And I have no disclosures to report. So today I'm going to talk about the epidemiology of smoking. I'm going to review evidence for the treatments for smokers who don't want to quit. And finally, I'll end with some specific recommended clinical approaches. And I'll also briefly discuss how to talk with your patients about vaping, because lots of patients tend to ask about that. So as you know, smoking is the leading preventable cause of death and disease. It causes 1 in 5 deaths in the U.S. That's about 500,000 deaths per year. Smokers lose many years of life, 10 to 20 years on average. And more than 16 million Americans suffer from at least one smoking-related illness. So the challenge that I pose to all of you is, what can we do to reduce and hopefully ultimately eliminate smoking so that current and future generations don't continue dying from smoking-related deaths? So this figure shows you smoking prevalence in U.S. adults starting in 1955 to 2017. We've made great progress when you consider in 1955 that almost half of the U.S. population smoked. So we're down to 13.9%. Though I do want to note that some disparity groups still smoke at a really high rate. Now, if we continue on this trajectory, smoking could theoretically be eradicated by 2050. That's not fast enough. If we don't get rid of smoking until 2050, millions and millions of people are going to continue to die from smoking. So the question is, what is it going to take to accelerate this progress so we could potentially eradicate smoking in the next 10 to 15 years? In order to treat it effectively, it's important to understand that tobacco dependence is a chronic disease. It's one that requires multiple quit attempts because it's a chronically relapsing disorder and multiple repeated interventions. It needs to be treated like, for example, hypertension or diabetes. You wouldn't ask someone at their appointment whether they wanted treatment for their diabetes. Smoking should be treated the same way. It needs to be addressed at every single clinical encounter using appropriate evidence-based interventions. Smoking is a physical addiction, a powerful physical addiction. When it's inhaled, nicotine reaches the brain in 7 seconds. And when someone smokes regularly, it leads to an upregulation in the nicotine receptors, and this results in a couple of things: in physical dependence, increased tolerance to the drug, so they need more and more of it to get the same effects, and finally, a withdrawal syndrome, a significant withdrawal syndrome when nicotine is withheld. It makes it really hard to quit. There's also a really important behavioral component of tobacco addiction. Smokers report that they smoke to feel better, to manage negative mood, to manage stressful situations. They also smoke in response to a variety of environmental cues. So people often smoke when they have their coffee or they drink alcohol or they're around other smokers. These situations become conditioned to elicit powerful cravings. So effective treatment really needs to address the multitude of smoking triggers in the environment. And this differs by smoker. Primary care is a really important venue for treating smoking. This is because 80% of smokers visit a primary care physician every year. Now, almost half of smokers report that they were advised by a healthcare professional to quit. But in Wisconsin, 82% of smokers report that they were advised to quit during a primary care visit. So great job, Wisconsin. We're doing a really good job. However, and this is from a recent MMWR report, only 5% of smokers leave their primary care visit with recommended evidence-based treatment for their addiction to nicotine. So why is it that so few smokers engage in evidence-based treatment for their smoking? I think there are a multitude of factors, but one really important one is that at any given primary care visit, only 70% of smokers are unwilling to quit in the next 30 days. So the majority of smokers are unwilling to quit. And most treatment offered in primary care settings targets complete cessation, so it's cessation focused. So we have a treatment reach problem because we don't have much to offer the 70% of smokers who just don't want to quit at any given clinical encounter. So it's really imperative that we start to develop and identify treatments for smokers who don't want to quit so that all smokers receive treatment for their addiction to nicotine. And of course, this is in keeping with a chronic care approach. Ideally, such treatment would increase their quit attempts and ultimately increase their abstinence, because that's the ultimate goal. So now I'm going to talk about the evidence for treatments for this group of smokers. So I'm going to review evidence from the PHS Clinical Practice Guidelines for treating tobacco dependence. This was last updated by UW-CTRI in 2008. So the guidelines recommend using the 5 A's when treating tobacco. So you ask every patient at every visit, do you currently use tobacco? And if yes, you want to find out what type of tobacco. Do they smoke? Are they vaping? Then you advise them to quit in a clear and personalized manner. I strongly recommend that you quit smoking. It's the most important thing you can do for your diabetes or your hypertension. So you want to be clear and personalized if possible. Then you assess, are they willing to make a quit attempt? Are you willing to quit? I can help you with this. I always like to add, I can help you with this, because a lot of patients don't realize that their provider can help them. If they say yes, they're ready to make a quit attempt, you assist with a combination of counseling and medication. The guidelines show that this combination of counseling and medication is most effective for treating smokers. Now, people who aren't ready to quit also need to be treated. This is the group that typically gets overlooked, and it, of course, makes up the majority of smokers. So not a great deal of research had been done prior to 2008 on this group of smokers, although there were a couple of recommendations from the guidelines. One is to use pre-quit nicotine replacement to increase abstinence. This was a meta-analysis from 5 studies, so not many, but enough to make this recommendation. And nicotine replacement could include patch, gum, or lozenge. There were also just a couple studies on motivational interviewing, or MI. So the guidelines recommended using MI to increase a smoker's likelihood of making a future quit attempt. There's still a great deal more to learn about how to treat smokers who are not yet ready to quit smoking. And I became really interested in this group of smokers a few years ago and started conducting research on identifying effective intervention components for smokers unwilling to quit as part of a center grant that was awarded to UW-CTRI. This research had a couple of key components. One was a focus on translation by evaluating treatments that were designed for real-world use in primary care clinics. And we did that around primary care clinics in southern Wisconsin. There was also a focus on chronic care through testing various interventions for every phase of smoking treatment. And this included smokers who weren't yet ready to quit. And finally, we focused on identifying treatment components that really work well together. And we did this through very powerful and efficient factorial designs that allowed us to screen multiple intervention components to identify which components work well together at each phase and which components don't work very well. So this research was guided by the phase-based model of cessation. This was developed by Dr. Tim Baker from CTRI. Basically, it says the process of quitting can be broken into very distinct phases, and each phase has its own opportunities and challenges for intervention. So here you can see there's the motivation phase, which is the phase we're talking about today, that involves smokers who are not ready to quit. Preparation phase, when someone is preparing or getting ready to make a quit attempt. There's the cessation phase, which involves treating someone who's ready to quit and they're making the quit attempt. Maintenance phase, which involves maintaining cessation once someone has quit. And finally, relapse recovery phase. Most smokers relapse, and so we're working on developing treatment to help them re-quit. So I just want to point out, too, that phases aren't necessarily sequential. This is different than the stages of change. It's really a treatment delivery model to guide physicians to tell them what sort of interventions to deliver for each phase. So participants were recruited from 11 primary care clinics in southern Wisconsin. Medical assistants were guided via EHR prompts, and they e-referred patients who were interested in quitting or reducing to our study. And then they enrolled in either one of 2 cessation studies or the Motivation Project, which was for smokers who weren't willing to quit in the next 30 days, but importantly, were willing to reduce. So they were willing to do something. So the goal of the Motivation Project was to identify intervention components that motivate smokers who weren't ready to quit to make quit attempts sooner than they otherwise would have, and to increase the success of the quit attempts. So I'm going to talk about results from several papers that resulted from this motivation study. First, I'd like to show you a video of one of the participants talking about her experience in this study. think it'll give you a nice context when I go in and show you the results.
I was here at the doctor, and they just said, do you want to take part in this PASS program? And so I said, okay. And I don't know why I said okay, but I did. It was a weak moment, and I said okay. I had no desire to quit. But that's because there's been no, cancer in our family. But I had started smoking in the garage, and winters in Wisconsin are cold. So that was sort of one of the things that made me think, okay, I should really quit. Plus, my grandchildren don't like it. And that was a big reason why I quit. So, yeah, cigarettes were my friend. But maybe they weren't such a good friend. But I didn't want somebody to tell me, you have to quit. I would just dig in my heels. I mean, enough is enough. It's my life, whatever. I had never heard about quitting and using the patch at the same time. So the fact that, okay, you were going to supply me with the patches, that was a good thing. The cigarettes didn't taste good anymore. I would go out there to have one, and and I'd just put it out. And then Caitlin would call me every week. Well, how are you doing? Okay, I'm doing fine. She encouraged me, and then she would remind me why I thought I would like to quit to begin with, which, I kind of forgot that one, and that helped. Gradually, doing this, all of a sudden, I could go 4 or 5 hours and not even think about a cigarette. Maybe I could do this. So then she called me, she said, are you ready? And I said, no. So she said, okay, we can, we'll go. I said, good. Thinking, January 31st is never going to come in my lifetime anyway, so let's just say January 31st. And then all of a sudden, January 31st was there, and I knew I had to do it. And so I said, okay, I did it. And I did it, and then I didn't want to let her down, and I didn't want to let anybody else down, because I didn't really want to fail at this thing. Somebody told me to think of it as a bell. It's something that rings, but it stops ringing. And that's been a real good one. The first couple days, I would find myself not knowing what I was doing, or I knew what I was doing, but I would leave something there and never finish a project and start something else, and I was really kind of crabby. But that was okay, because I deserved to be crabby once in a while. And then that left, and it's okay. I mean, and each time you do it and it's okay, it makes it easier. I'm not gaining weight, and I'm not consumed with eating. And I've read that little book over and over and over that comes in that package. So far, I'm really pleased, because like I told you before, maybe I'm stronger than I thought.
So I think she really characterizes smokers who aren't ready to quit. A couple of things I noticed is she reported she initially had no desire to quit. At the end of the study, she ultimately did. And she had no desire to quit, but she still entered treatment. So she was willing to do something. She didn't want to be told to quit. She didn't want to be badgered. Once a patient tells you they're not ready to quit, you back off and you use different sorts of interventions, different approaches, MI, reduction goals, and we'll talk about all of that. It sounds like maybe she did a little MI. She was exploring reasons for quitting, talked about the importance of her grandkids. She also talked about increasing the length between cigarettes. So she was maybe learning some important skills that helped her when she did finally become ready to make a quit attempt. Sorry, I gotta find my cursor. There we go. Okay, so the study is a 4-factor, fully crossed, randomized design. It yielded 16 different conditions. Now, all factors had 2 levels. There was an on and an off level. So for each factor, 50% of the sample received the on condition and 50% received the off condition. So the first intervention component was nicotine patch. Again, I want to remind you it's pre-quit. They were still smoking. So this involved 6 weeks of patch for those in the on condition and none for those in the off. The second intervention component was pre-quit nicotine gum. And this involved 6 weeks of gum in the on condition versus none in the off condition. The third intervention component was reduction counseling, and this involved 1 in-person visit in 6 phone sessions for the on condition, none for the off. And reduction counseling involves working on reducing smoking through a variety of strategies. I'll talk about this more later, but delaying smoking, changing your patterns, coming up with smoking substitutes. And the 4th intervention component was motivational interviewing strategies, and this involved 1 in-person visit and then 3 phone sessions over the 6-week intervention period versus none in the off. And this involves developing discrepancies between what someone's doing now, which is smoking, and their future goals, eliciting self-motivational statements, and so on. So the intervention period occurred over 6 weeks. All interventions started with an in-person clinic visit at the participant's clinic. All other intervention contacts occurred by phone. And then all participants received 6 weekly assessment calls regardless of their intervention schedule. Now, at any point during the 6-week intervention, a participant could decide, I'm ready to quit, and opt into cessation treatment that was provided by the study. And this involved 2 brief cessation-focused counseling sessions. So they no longer received motivational counseling. They received cessation-focused counseling, and then 8 weeks of patch plus gum. Now, at the end of the 6-week intervention period, participants also had an option. They could actually repeat the 6-week motivational intervention that they just received, or they were asked, do you want to quit at this time? So they could receive the cessation intervention at that time, or they could say, I'm done with you, I don't want any more treatment. So the goal was to move smokers not ready to quit through different phases of the quitting process, from motivation to cessation. So this really was a step towards developing a chronic care model of smoking treatment. We're trying to move smokers along. Participants needed to be 18 or older to be in the study. They needed to smoke 5 or more cigarettes per day in the prior 6 months. They couldn't be using bupropion or varenicline and medically able to use nicotine replacement. And importantly, they needed to not be interested in quitting in the next 30 days, but willing to do something, willing to reduce a little. We enrolled 517 participants. 63% were women, 91% white, 5% African American, 15% had a college degree or higher. They were an average of 47 years of age and smoked about 17 cigarettes per day on average. I'm going to share with you a couple key outcomes. One was participation. We wanted to know whether smokers who don't want to quit will engage in treatment. Will they do anything? And once they're in treatment, will they stay in treatment? We also looked at which of those 4 intervention components that I talked about increased serious quit attempts, so of 24 hours at least. And finally, we looked at what intervention components increased abstinence. So for the first outcome, participation, of the almost 1,700 smokers who enrolled in the overall parent project, 30% were not interested in quitting and enrolled in the motivation study. So what this means is when primary care patients, remember they weren't seeking smoking treatment at the time of the visit, when they're offered a choice about what sort of smoking treatment they would like to be in, a good chunk, 30%, were unwilling to quit but willing to enter motivation treatment. So that was significant to us. And once they were in the study, participation was excellent. Participation never went lower than 70% across all of the counseling calls. This might be because we really never badgered them to quit. During these calls, the counseling was really designed to be quite supportive while still moving them towards the goal of reduction and ultimately cessation. But I think it felt very supportive to participants. Participants also enrolled in additional treatment, and I was actually pretty surprised about this. 21% wanted an additional 6 weeks of motivation treatment, the same intervention they just received. They wanted more. I think they liked the support, maybe recognized they were making progress, were happy with their reduction. And almost a quarter, 23%, opted to go into cessation treatment and said, I'm ready to quit. Again, remember, these were participants who really only a couple weeks prior said, I don't want to quit. All right, so now let's look at the second outcome, making a quit attempt. Which intervention components predicted making a serious quit attempt? We had only one main effect of gum. And here you can see that at 6 weeks, at the end of the intervention period, those who received gum were more likely to make a quit attempt than those who received no gum. All right, now looking at the abstinence outcome, we had two main effects, and this is at 12 weeks. Those who received reduction counseling were about twice as likely to quit as those who received no reduction counseling. And this one surprised me and all of us, quite frankly. Those who received patch were less likely to be abstinent than those who received no patch. So now I'm going to show you some abstinence results for that subgroup, that N of 100 who received specific cessation phase treatment. A lot of them quit with no cessation treatment, but we wanted to look at the effects of motivation phase treatment on those who transitioned to receive cessation treatment. We found no main effects, but did find a significant two-way interaction between nicotine, gum, and reduction counseling. And here you can see that those who received a combination of gum and reduction counseling were the most likely to be abstinent at 6 months. And actually the abstinence rate is really high. 46% is incredibly high. Now the caveat is we couldn't use bioverification due to the nature of this study, but it's still really high. It also looks like using cessation treatment when a participant became ready to quit was really important. So in this figure, you can see the original N of 517, and 17% of those made an intentional serious quit attempt while using cessation phase treatment, the treatment that we provided to them. And at 6 months, 42% of those participants were abstinent. Now let's contrast this to the self-quitters. Those who didn't receive cessation treatment from the study, 36% of the sample made an unaided quit attempt with no cessation treatment, and only 10% of those participants were abstinent at 6 months. So it appears that cessation treatment is a really important component of treating smokers who aren't yet ready to quit. Of course, it's also possible that the most motivated smokers might have been the ones who chose to receive cessation treatment, but we still think that it's really likely that readily available cessation treatment is a really important part of treatment when you're trying to treat smokers who aren't yet ready to quit. So one of the really important questions is, are we actually expanding treatment reach? Are we treating more smokers than we otherwise would have if we were just offering cessation treatment? And in support of this notion, we did find some differences between those who selected reduction versus cessation. So patients or participants who entered reduction versus cessation treatment were a little bit older. Not surprisingly, they had a lower motivation to quit. They also had some characteristics that actually increased their risk for cessation failure, more likely to have a history of anxiety, more close friends and family who also smoke. It had been a longer period of time since they last made a quit attempt, so a little reluctant to quit. And they also had higher alcohol consumption. So perhaps these smokers, because of their risk factors, were a little more reluctant to enter cessation, and reduction seemed like a more feasible goal. So we think it's possible that offering reduction treatment might actually induce smokers to enter treatment who might have otherwise avoided quitting, at least initially. So I'm going to give you a couple conclusions from this research before we move on to the other part of this talk. Participation in motivation phase treatment was excellent. Smokers who are not ready to quit will engage in treatment, and they tend to stay there. Nearly half wanted more treatment. Across the set of analyses, nicotine and gum and reduction counseling were the most promising motivation phase components. And it also appears that ready access to evidence-based cessation treatment is a really important part of reduction treatment. So you might have noticed that we had one unexamined group. It's smokers who don't want to quit, and they actually don't want to make any changes. They're good. They don't want to reduce. They don't want to gain control over their smoking. And there are definitely those smokers out there. Those smokers who don't want to make any changes still need to be treated. So the question is, how can we increase treatment use and abstinence in smokers who don't want to change? I am excited that I get to start to evaluate this question. I just had a VA merit grant funded that will examine treatment aimed at increasing both treatment use and abstinence in 500 veterans who are unwilling to quit. And that will be right here at the Madison VA. Veterans smoke at a really high rate. Smoking is a big part of military culture and life. And I'm really excited to try and identify a treatment that will help veterans use more treatment and hopefully quit. All right, so now let's move on to some specific recommended clinical approaches. What do you do with smokers who are not ready to quit? One thing I just want to remind you all of is that the guidelines say that interventions lasting as little as 3 minutes really increase overall abstinence rates. So let's say you have only 2 smokers a day. This might only add about 5 to 6 minutes to your day. So the recommended clinical approaches that I'm going to briefly talk about are motivational interviewing, or MI, reduction counseling, and nicotine replacement. So just going to overview some important components of MI. It's for a smoker, again, keeping in mind that these are smokers who have said they're not ready to quit. So none of these strategies need to be done when you learn someone is a smoker. You start to use these strategies when you've asked if they're ready to quit and they've said no. So it's really important to be open to a patient's ambivalence for quitting. Just think about your own life. Change is really difficult, and it's important to sort of frame your approach in that way. Always express empathy with MI. It makes your patient feel like you're on their side. Saying something like, you're dealing with a lot of stress at work. I can see why it would be hard to make a quit attempt right now. Patients feel supported when you make statements like that. Always support the patient's autonomy, especially for a patient who said they don't want to change. We all know that the second a patient walks out the door, they're in control of what they do. Sometimes I say, only you know when the time is right for you to quit, and this can be sort of empowering and motivating for patients. And also with MI and for patients who aren't ready to quit, it's really important to elicit reasons for change from the patient. If you tell them at this point why they should change, they often feel sort of lectured to. It can increase resistance to change, so it's important to elicit their reasons for change and then reflect them back to your patients. And that increases motivation. MI also helps patients recognize the difference or discrepancy between what they're doing now, which is smoking, and the things they value and their goals in life. Discrepancies, these internal discrepancies, make people kind of uncomfortable. And that's okay, because those discrepancies can, when you help highlight the discrepancies, they can make people sort of uncomfortable and motivated to make some changes to diminish the discrepancy. So for example, you could help someone become aware of this discrepancy between her current smoking behavior and the things she likes about smoking versus how much she loves her grandkids and her desire to be a part of their life and see them grow up. And if you simply reflected those two sides of the coin to your patients, you're not telling your patient what to do, you're reflecting what you've learned from the patient. That can be really motivating for your patient. Now you can do some specific exercises. These are really quick to help develop discrepancies. You can do a decisional balance. So what is it that you like about smoking? Smokers love to talk about what they like about smoking, and they're always surprised when I ask them that. And then on the other side, are there things that you don't like so much about smoking? Or if you quit, how might your life be better? And then you really just reflect both sides, but emphasize the reasons supporting change a little bit more. You could always just ask a simple evocative question. So I understand you're not ready to quit, and that's okay. But if you were able to quit someday, how might your life be better? So what you're doing in MI is trying to collect and gather information from the patient. You're eliciting this information. It's information that supports change and reflecting it back. All right, reduction counseling. So the goal typically is to set some specific reduction goals. We typically say 1 to 2 per week. You want them to make small incremental changes. And then you can recommend having your patients replace their cigarettes with nicotine gum or mini lozenge, so use it as a substitute. You can work on strategies to help them stop smoking in certain places or situations. So like in their car, when they're drinking their morning coffee, to start to gain some control and break some of these strong associations. And they can also work on delaying smoking, such as that first cigarette in the morning, which is typically the cigarette that people need most because they've been in withdrawal from the night before. So reduction could help patients quit eventually in a couple of ways. If they reduce their overall level of smoking, it might help them reduce their nicotine dependence a little bit, which should make it easier to quit. It also helps them learn some skills, the very same skills that they'll use when they actually make a quit attempt. And this can also increase confidence and self-efficacy, and we know that's predictive of success when someone tries to quit. It also can just help break those associations between trigger situations and the cigarette, so like driving, coffee, stressful situations. So nicotine replacement therapy. So NRT is safe when used while smoking, and it's FDA approved. You could prescribe, or your patients could use nicotine patch or nicotine gum or mini lozenge. Based on our recent large clinical trial, we recommend using nicotine gum and mini lozenge, 2 milligrams used to substitute cigarettes directly, up to 10 per day. And also, I just want to point out this worksheet that we made at UW-CTRI that you can use for your patients who are not ready to quit. You can get it through UConnect, and it actually combines all of the elements, all of the treatments that I just talked about. There's a little MI, reduction, and NRT. So you can print this out, give it to your patient, have your patient write this information down. What are your reasons? What are some of the reasons you like smoking? And what are some reasons that you might like to quit in the future? Reflect these back to the patient if you have time to do that. And if not, it's just helping them sort out some of their motivations for smoking. Then do a little problem solving. What do you think is getting in the way of your quitting? Sometimes you'll learn something that you can address. Patients will say, oh, withdrawal is terrible. I've tried to quit a lot of times. And you can say, you know what? We have evidence-based treatments that will take the edge off withdrawal. It will really help and increase your likelihood of quitting. Patients often just don't have enough information. And then finally, you can say to your patient, I've got some small steps that might help you work towards gaining some control over your smoking and maybe get ready to eventually quit someday. Let's take a look at some of these steps and see if you'd like to try one. So you could cut down, reduce your cigarettes by 1 to 2 per week. You could use some medications, lozenge, gum, or patch, and I can help get you set up with that. You could work on stopping smoking certain places, or you could work on delaying some cigarettes. Would you like to try any of those and have them check it off? And finally, you're giving them information about what to do if they become ready to quit. Here's the number for the quit line. If you become ready to quit, it's important to set a quit date, to get medications, and you can get that from me or from the quit line. And it's important to get support from friends and family. Let people know you're quitting, because those are really elements of a successful quit attempt. Also, just want to make you aware of treatment extenders. So you can send your patients to the Wisconsin Tobacco Quit Line, which involves free coaching and support and 2 free weeks of medication. There are websites. I want to highlight NCI's, smokefree.gov. It's excellent. It provides information on evidence-based strategies for quitting. So basically, this allows you to extend treatment beyond the 3 to 4 minutes that you can spend with your patient in any encounter. A little bit more about the quit line. You can e-refer patients to the Wisconsin quit line, even if they're not ready to quit. The quit line will call your patients back. You can find this e-referral through HealthLink in the Tobacco Smart Set. And you enter the patient's phone number and the best time for the quit line to call them, and the quit line will try and reach them up to 5 times. All right, so finally, I want to briefly talk about e-cigarettes because a lot of people have questions about vaping and patients are talking about this. So nicotine, for e-cigarettes, nicotine is delivered through vapor, so it's heated, not burned, like smoking. And it comes in a variety of types and flavors. E-cigarette is, it's increasing or stabilizing in adults, but it's rapidly increasing in adolescents and youth. And there's some areas of public health concern. One is the lack of regulation. This is a completely unregulated market. The youth uptake is a huge concern. We're not going to know for a really long time anything about the long-term health effects. It's going to be years before we can evaluate those data. And finally, we have some concerns about dual users. Those are people who both smoke and vape. So as I mentioned, the market is totally unregulated. There are many different delivery systems. It's a very quickly changing landscape. The newest kid on the block are Juuls. The innovation from Juul is to use something called nicotine salts, which really just delivers more nicotine, so it's far more rewarding. Lots of youth and adolescents are Juuling. What's particularly disturbing about this is a lot of kids report that they don't even know there's nicotine in these devices. They don't know what they're inhaling. Now, there is nicotine in all Juul devices, but kids sometimes don't know it. And there's concern that it's leading them to uptake combustibles down the road. So what do you say to your patients about vaping, especially in light of this ongoing debate about whether e-cigarettes really could be used as a harm reduction approach? You can say that e-cigarettes are safer because there's no burning or combustion. So they're safer than combustible cigarette products like cigarettes, but we definitely don't know they're safe. My colleague, Megan Piper, is taking up that research. E-cigarettes might help people cut down, but we don't have definitive evidence that they help smokers quit. It's important to tell your patients that there are safe and effective treatments for helping you reduce and quit, counseling and medications. So it's important to try and guide them towards those evidence-based treatments rather than vaping. And really the bottom line is the ultimate goal should be complete cessation of combustible cigarette use, and really dual use isn't a good long-term solution. All right, so I want to go over a couple key takeaways from this talk. One is that 70% of smokers, so the vast majority of the smoking population, may not be ready to quit at any given clinical encounter. These smokers need to be offered treatment at every visit. There's evidence that counseling is effective, MI or reduction counseling, and pre-quit NRT is effective. Just remember that you can use treatment extenders like the Quit Line and different websites. And remember to make sure that patients have access to evidence-based cessation treatment when they do become ready to quit. I want to thank all of my wonderful colleagues at UW-CTRI. Thank you.
So, Dr. Cook, that was fantastic. Let's take questions from the audience.
Yeah, that's a great question.
Can you repeat the question?
Oh, yes. The question is, as I mentioned, there's this unexamined group. It's people who they don't want to quit, and they also don't want to make any changes. And the question was, what percentage of the smoking population does that make up? What portion of that 70%? And at this point, it really would be just a guess, but I might say about half of that group. Yes.
That was wonderful. So when you ask people what might motivate you to quit, money, health,
Yeah.
grandchildren, whatever, what are the most common reasons you hear that people will bring up as maybe life could be a little better?
Yeah. So the question was, what are some of the more common motivators for making a quit attempt? It sort of depends on the population. When I'm working with veterans, and many of them tend to have lower income, for many of them, money is a big factor. Cigarettes are really, really expensive, and that can be a big motivator. For some people, especially people with kids or grandkids, they'll talk about being a role model. They don't want their kids to start smoking, and they want to be a good role model for their kids, and they want to be around to see them grow up. For many people with current smoking-related illness, health is obviously a big motivator, whether it's emphysema or diabetes or whatever it is they're dealing with. That can be a very powerful motivator as well. There's also some people who they know they're addicted and they don't want cigarettes to control them anymore. They want to regain some control, and that can be a really powerful motivator for people to really gain some control in their life and not need to smoke every hour or so throughout their day. So it's a great question. Yes? So the question was, what portion of those unwilling to quit are willing to reduce? And again, I'd say based on our data, maybe about half or even a little less. The second part of the question was, is there any evidence that cutting back, maybe to half a pack or so, is beneficial for health? The answer to that is there's no safe level of smoking. Even one cigarette a day is detrimental to your health. And I'm glad you raised that point. The goal of reduction treatment, it's not a harm reduction approach to get people smoking fewer cigarettes. The ultimate goal is cessation. We use reduction as an easier step, a more approachable goal. And once they're reducing, you hopefully increase confidence and skills and decrease dependence and ultimately get them to quit. So great question. It's a really important point. The ultimate goal of motivation phase treatment or reduction is complete cessation. Yes?
That was a great thought. Thank you.
Thank you.
I wonder if there's any correlation between number of cigarettes a person smokes and their willingness to reduce, if you want. And then with Don's question too, those patients who go into reduction, if that more successful, that started at a smaller number of cigarettes.
You know what? So the question was, is there a level of cigarettes that is associated with choosing to reduce cigarettes, and is that level also predictive of someone's success? The answer is, I don't know, but we could answer that by looking at the data. I can say that we have looked at the amount that someone reduces once they've been in, and from the data I looked at, there was a cut point right around 50-55%, where a huge amount and participants ended up abstinent. So if you can get people to cut down 55-60% of their cigarettes, there's a very high likelihood that they're going to be able to quit. Yes?
The treatment that you had, since
What are ways to counsel smokers when they're around a lot of smokers? They live with smokers or people in their social group smoke. Great question. It's one of the main predictors of failure to quit. It's really hard when you have constant reminders of cigarettes in your environment. We talk with patients about this and recommend that, for example, if there are smokers in your social group, we recommend that they tell their friends, I'm trying to quit smoking, spend a little less time around them, or if you smoke, could you go outside? If they live with smokers, that's a little trickier. It's important to have someone quitting try and designate some no-smoke zones in their house, so no ashtrays, lighters, or cigarettes, and have the smoker they live with either smoke outside or smoke in a designated room. So it does make it hard, but there are things people can do to modify their environment that makes it easier. Yeah. Yes. Right, and that's a great point. Although we do have effective interventions for smokers, certainly there's a lot of research that shows that taxation of cigarettes has played a strong role in reducing smoking prevalence, as has smoking bans in public areas. Great question. Yes? Is there evidence that e-cigarettes will be regulated in the future? I believe there's no evidence right now. I believe there have been attempts, talk at FDA. It was something that I believe was potentially in the works, and it has been pulled off the table, unfortunately, and we were really disappointed about that. Yes?
I know the VA work is starting to have, I'm curious about military culture and the role of smoking in that perspective. Could you share anything that you might know about how the military is trying to change?
Yeah. Yeah, you know, and even as recent as Sorry, yes. So the question was to just talk a little bit more about the role of the effects of military culture on smoking and how the military is addressing this. As recent as Vietnam, and maybe even after that, cigarettes were provided to military personnel in their rations, which was obviously a really tragic thing. A lot of military personnel became addicted to cigarettes from the cigarettes provided in their rations. More recently, the military is taking some steps to address this. All tobacco products are banned during basic training. So at least that's one period when military people can't use any tobacco products. Unfortunately, you know, we still have, around VAs for all sorts of reasons, we still have places for veterans to smoke. And veterans and military personnel can still buy cigarettes at a really, really low price. There are steps that different people are trying to take to address this, so it's something that we're continuing to work on.
Thank you very much. Fantastic.